All right, good afternoon, everyone. Let's try that again. Good afternoon, everyone. There we go. You gotta make sure you're awake. I know you end of the week and you've had a lot of classes, so I'm sure you're ready for the weekend. But thank you for joining us today and around this topic especially. My name is Ryan Simpson. I'm with the Health Science Center Office of Diversity and Inclusion. And I also need to mention some of our co-sponsors for today. One is the Kentuckians for Single Payer Healthcare, the Kentucky Chapter of Physicians for a National Health Program, and the School of Medicine Office of Community Engagement and Diversity. The title for our lunch discussion today is Clinicians as Change Agents, the Professional Imperative to Advocate. To guide us in this topic this afternoon is Dr. Margaret Flowers. Dr. Flowers, Baltimore pediatrician, is a national expert on the single-payer solution to our country's healthcare problems. As a congressional fellow for the Physicians for a National Health Program, she was among the physicians and others arrested in 2009 when they boldly stood up at a Senate Finance Committee hearing to insist that single payer have a seat at the table. While she was not allowed to speak that day, Dr. Flowers has written and spoken extensively to build public support for passage of H.R. 676, which is the Expanded and Improved Medicare for All Act. She testified before a Senate committee and a presidential commission and has been interviewed on The Bill Moyer Show, The Ed Show on MSNBC, Frontline, Democracy Now!, and other media. Dr. Flowers views the healthcare struggle as a part of a broader social, economic, and environmental justice movement. She left her medical practice to advocate full-time for a healthcare system that will put health over profit and give all Americans the care enjoyed by residents and of other advanced nations. So let's welcome Dr. Flowers.
Can you hear me? There we go. Can you hear me? This test, there we go. Okay, great. Good afternoon, everyone. How are you doing? So, initially, I thought this was going to be more of an interactive kind of get-together, and then I was asked to speak about a few things. So really, I just want to talk for a few minutes and share some of my thoughts with you, and then I hope that we can really make this much more of an interactive conversation. I know some of you are still eating. I'm going to ask Dr. Carol Paris, who's a friend and colleague and current president of Physicians for National Health Program, and another one of the 8 that was arrested in the Senate Finance Committee, as well as we've done some other fun activities together, to come up and join me as well and share with you some of the work that she's been doing too. But how many of you have ever had someone tell you that medicine is not political, or don't make it political, or you can't be political, right? I'm glad it's not too many, because that's good. That's a good sign, maybe. The reality is that medicine is political. One of the motivations that I have could be summed up in the phrase that I think of frequently, which is that to be silent is to be complicit. So even by not taking action, we are actually making a political decision. If we see an injustice, to not do something is a decision to allow that injustice to continue. And throughout my life, I just have not really been able to do that from a very young age. So I wanted to share a little bit of kind of my path from medical school to here. I won't go into too much detail, and then talk a little bit about kind of activism in general. So when I was in medical school in Baltimore in the 1980s at the University of Maryland, I just immediately became active. I was living in a city with fairly high poverty rates, a lot of homeless people. I used to do volunteering there was a kitchen that provided food to people close to the medical school. I went there. I also went out on vans that delivered food and talked to homeless people and helped them get into shelter, especially in the wintertime. I was president of the American Medical Student Association chapter at my school second year, and also president of the American Academy of Family Physicians, or whatever, the family practice club that we had at my school, even though I ultimately went into pediatrics. I wasn't sure at that time which way I was going to go. So I was always kind of had this leaning towards organizing and being involved in things. Then residency at Johns Hopkins, I also had 2 children during my 3 years there, so that was not a time of being very active. And then I got out and I went into practice. And I started out as a hospitalist. That was when hospitalists were fairly new. And there was a rural hospital in Maryland, and they wanted to have 24-hour pediatrics and OB in the hospital. And so we worked together. We based the pediatric office out of the OB ward, although we also covered the emergency room when they had kids that came in and they needed consults. We also managed kids on the floor. It was like an 8-bed pediatric unit. It was not huge. But while I was there, we were able to do a lot of really great things. This was, we had to push the hospital a little bit, but we did, got them done. I was active in what was called the HOPE program, which was Hopkins Outreach for Pediatric Education. And we trained the emergency medical providers in and around Baltimore in, advanced pediatric life support and things like that. I think one of my first experiences of having an infant come into the ER was an 8-month-old that came in not breathing, and they were using an adult mask to try to resuscitate him. He died, and that made me realize that they didn't even have pediatric equipment on the ambulances out in the county where I was. So we worked to change that. We didn't have pediatric crash carts in the hospital, and so we changed that. That was a time when we were able to introduce using sedation for pediatric procedures, like various radiologic procedures. So that was all really exciting. We pushed and got a level 2 nursery because we doubled the number of deliveries that we did there from 600 to 1,200 in the time that I was there, and they only had a basic nursery with very little in it. And that was another experience I had very early on. I had twins that were born by C-section, and a couple hours after birth, they started crashing, and they had a severe infection, and we had to resuscitate them and get them out to another hospital. So we were able to create a level 2 nursery where we could do more resuscitation there and support infants down to 32 weeks to keep them in the community. So I felt like I was doing some really great work. At the same time, I was fighting with the hospital all the time when we would admit pediatric patients, and they would say, well, you have 3 days. And I'd say, well, that's not actually cool because we need longer than 3 days. And so we had to push back quite a bit successfully. Actually, we were lucky that the administrators, it was a small enough hospital, they were willing to work with us. And if we said, this child's not ready to go home, or this family's not ready to take this child home, they would, find a way to figure it out. And we just worked really hard to say, look, if people trust bringing their children here, if they trust having their babies here, it's going to be good for the reputation of the whole hospital. So don't expect us to make money, and we'll just do our best to provide good care and have a good reputation. And so anyway, then I left that because by that time then I had 3 children, and I was working 12 and 24-hour shifts and never really sleeping. And after a number of years, that wasn't working out so well, so I went into private practice. And that's when it really hit me how our healthcare system is a problem for primary care physicians. We really fought with the insurance companies constantly to get paid. And so more and more our office staff was pushing us, primarily our office manager, in a direction of spending less and less time with patients. So finally kind of got to me, the last straw was when she said, well, you can only do 1 well child visit a day because they take too long, and the rest of the visits have to be sick visits, and if you're taking too long, I'm going to knock on the door, and if they have more than 1 complaint, you're going to have to schedule a second visit for the other complaint. And I just said, I was getting pretty fed up anyway, and I was trying to do advocacy by that point. I was about 3 years before that, I had started kind of trying to figure out what the heck was going on, like why were things this way? And what could we do about it? And so that was kind of one of those moments where I said, okay, advocacy has got to be the road. And I was also seeing a lot of my friends from medical school and residency, and my ex-husband was also a surgeon, his friends, leaving practice and going into more administrative positions because the same frustrations. It tended to be the same people that I thought were like the really good docs or the ones who were burning out and going into administrative positions. So I thought, well, something's got to be done. And if I do this full time, I'll maybe have a better chance of being effective. And some of my friends were not willing to speak out because they were worried about retaliation for doing that. And so I thought, I'm going to be free. Nobody can retaliate against me, right? They can't take away my privileges. They can't drop me from their insurance panel because I'll be independent. So I naively thought I was going to do this for just a few years, and then I'd be back in practice and we'd have everything fixed. It didn't quite work that way. But during this time that I've been advocating, I've also been trying to figure out, so how does this actually happen? How do we actually win? How do we actually achieve changes? And there's a lot of research on this, and there's a lot of information about what works, and social movements have stages, and what those different stages require, and the tasks and the challenges that you're going to face, and how you overcome those. So that's been a whole nother part of, in addition to the work for single payer, is just kind of figuring that out, because I didn't want to be an activist as just for the sake of being an activist. I'm not doing this because it's a fun thing to do. I'm doing this because it needs to be done, and I want to win, right? I don't want to tell people to do something that's not effective, just like we wouldn't tell our patients to take a medicine that doesn't work. We shouldn't be telling activists to do activities that aren't part of a strategy and part of a campaign to actually win something, right? So just want to leave you with some thoughts on social movements and you and your own decisions, because there are part of the work on social movements tells us that there are different roles that are of people in social movements, and different roles that are required, particularly at different phases. And there's a longtime activist and academic, George Lakey, who's written about how these four roles also actually kind of, you can see them in people's personalities beginning at a very young age. So kind of how we each individually approach problems that we see in our life. And so one of the roles is the reformer. And reformers are people who tend to be more policy-oriented. They might be people that are more likely to want to write legislation and talk to legislators and get them to pass it. They're people that generally turn to authority when there's a problem. So if you were in school when you were young and something came up and your tendency was to run to the teacher for help, or an authority figure in your community for help, then you might be more of a reformer kind of person. And this is an important role. We need people who can translate the policy changes that we need when we see something in our society. How do you translate that into language to change something? And also reformers tend to be watchdogs. Once whatever change you've gotten into law is made, then you need someone to be watching and making sure that what you wrote is actually what's happening, right? So I know physicians that are very comfortable with the reformer role, and they like to work with legislators and talk to them about policy and things like that, and that's an important role. A second one is called the helper role, and these are, if you were more the person in your childhood who, when you saw a problem, just directly wanted to intervene and fix it. So there was trash on your street and you got out in the street and you cleaned it up. Then you're maybe more of a helper person. And think of people that do direct aid. And again, I know physicians that are more comfortable in this role. There was a doctor out in New Mexico who I met who worked in a university medical practice, but he wasn't happy with that. And so he started working with an underserved community in Albuquerque. And they opened up a small clinic that was created in cooperation with the community. They helped to determine what that clinic was going to be like. They actually had like a small room where community members could come in, and they brought different candles and things that they put in there to make it their space, and they would hold community meetings in there and education and things like that. And he didn't have any billing structure in this clinic. He charged a very small fee for people that came there for care. And he had a 98% payment rate because the community was so invested in this clinic that they would literally stop by every week and pay $5 or $10 towards their bill. And so, it was a very low-staffed clinic. And it has since grown, and he's brought on other doctors to that clinic. So he just didn't want to be in corporate medicine. I'm getting out, and this is what he did. Another role is the organizer. So if when you were young, you saw a problem, you tended to want to get a group of people together and start to say, okay, what are we going to do to change this? You might be an organizer. And there's a long legacy of physicians who have been organizers. Think of Physicians for National Health Program, Physicians for Social Responsibility, Physicians for Human Rights, Medical Committee for Human Rights, lots of doctors who got out there and organized to make changes in their community. And where I live in Baltimore, we have a lot of doctors that are involved in kind of environmental injustice campaigns, and they're very much welcomed by the community because we can bring that expertise, and they always like turn to us and they say, okay, can you talk about the health effects of this, pipeline or whatever? And when we stand with them in solidarity in their actions, they really appreciate that. And then the fourth one is the rebel. And so this is somebody who maybe when you were younger and you saw an injustice, you were going to make a commotion and say, hey, but this has got to be fixed. This is wrong. Let's do something about it. Raise a ruckus. And I've known many rebel physicians as well. And one of my colleagues, another Physicians for National Health Program doctor, was actually a resident at Lincoln Hospital in, I guess it was around 1970, when the residents were upset that the hospital was not providing appropriate services to the Latino community. There was a group called the Young Lords, a lot of Hispanic and Puerto Rican people that organized similar to the Black Panthers. And they took over a department of the hospital for a little while. They just took it over and said, we're going to run it our way, and we're going to bring the patients in, and we're going to treat them. And that was then put the pressure on the hospital to do the right thing. They had been trying things before that, but that's kind of ultimately where it ended up. And I know some other of my mentors, particularly in Chicago, there was a lot of work done around racial discrimination in hospitals and making sure that people could get the care that they needed in their community. So these are some of the roles, and I think that for each of us as physicians, it's important for us to decide, do we want to be activists in any way? Maybe you're here because you're leaning that direction. And what kind of activism fits into what I see myself doing? Because there are all different levels of activism that you can engage in, and it's just finding out something that is satisfying for you. And I wanted to bring Carol up, if that's okay. So I should introduce Carol. Dr. Carol Pears is a psychiatrist, and she practiced in Maryland as well. And she also spent a year practicing in New Zealand to see what a single-payer system was actually like. And she's current president of Physicians for National Health Program. Anything else you want to say about that? All right, why don't you say?
Well, I'm wondering if some of you are already members of Students for a National Health Program. Can I see a show of hands? Great, glad to have you. If you are not and you are thinking that this sounds like an idea you'd like to be a part of and join, we actually have paper, but I know you'll do it online because you don't use paper. But just so you have something, you can join PNHP as a student for free, and that puts you directly into the a SNAP chapter. Well, it doesn't put you into a SNAP chapter, it puts you into PNHP. Well, what we will do then is, if your school already has a SNAP chapter, you will be a member of that, and if they don't, then we would encourage you to create a Students for a National Health Program chapter. I am really happy to say that in the 2 years I've been president of PNHP, we've added, I think we're up to 18 or 19 more SNAP chapters around the country, so our total is somewhere around 75, somewhere around there, chapters. I think this is really important. When I have asked medical students to think about a mentor, someone, an older physician, or the people that you are in training with, who are training you, how many of them strike you as mid or late career physicians who are still happy and motivated and enjoying medicine? And what I often see is people snicker and look down, because the fact is so many mid and late career doctors are becoming disgruntled and burned out. one of your colleagues, Leo Eisenstein, had an article in the New England Journal of Medicine, August 9th, 2010. The title is "To Fight Burnout, Organize." And I've said that myself, that I met Margaret in 2009 when I was becoming a pretty disillusioned, disgruntled private practice psychiatrist who felt like the system was turning me into a prescription writing machine. And that's not what I went into psychiatry to be. But baked into our insurance fee schedules is a financial disincentive for me as a psychiatrist to spend time with patients. So they'll reimburse me really well to do 15-minute med checks, if everything looks like if all you have is a hammer, everything looks like a nail. That's kind of the mentality they want us to have as psychiatrists, that the only hammer we have anymore that reimburses us is a prescription pad. Well, and for me to see a patient in therapy for 45 minutes or 50 minutes, if I did that with every patient who needed therapy, I would have gone bankrupt. So I got disillusioned, and I met Margaret, and she started helping me understand what single-payer Medicare for All is. And I really think that's what allowed me to continue to practice for 3 or 4 more years without completely throwing my hands up in disgust. I ultimately did leave practice a few years earlier than I needed to, and as she said, I worked in New Zealand for a year because I wanted to actually be able to say, look, I've worked in a country that has a national health program, and guess what? It isn't perfect. It's just a whole lot better than what we do in this country. And if when we pass single payer in this country, it won't be perfect. It'll just be a whole lot better than what we're doing now, and we will need to continue to improve it and to hold everyone accountable to making it that way. So there's just one other article that I want to call your attention to that was in Kaiser Health News, October 1, and the title is "White Coats as Superhero Capes. Med Students Swoop in to Save Healthcare." You guys are getting press. What you say, what you think, people are finally beginning to listen to. Your voice is way more important than you realize. It is compelling to speak to legislators and say, hey, I'm the future of healthcare, and I want to practice in a sane system that pays me well, but also allows me to practice in a way that I feel good about, that I feel is ethical. So I'm just going to encourage you to speak up. I don't know if I can pull it up anymore. Yeah, I can't. It's gone. But one of my mentors in medical school at WVU said to students in 2003, he was admonishing them to speak up and to become politically involved. He said, the doctors of my age thought that being politically involved was beneath us, that our job was just the good care of patients. And he said, that's not true. Please get involved, speak up. We have a responsibility beyond the good care of patients, one at a time. We have a responsibility to provide a good healthcare system. So I think I'll stop there.
So there's microphones on either side. If anybody wants to get up or ask a question, you can just... Oh, that's right. While you're doing that, I do want to mention that we are having a demonstration this afternoon at 4 p.m. in front of the Humana office building, which is 500 West Main Street, and everybody's welcome to join us. Go ahead.
All right, so I just want to, and you kind of touched on this last night at the Hotel Louisville event, just what kind of gives you hope right now with the single-payer movement and some things that are going on that really make you excited and feel like you can keep doing this?
Yeah, thank you. So I mentioned that social movements have stages, and when we look at kind of where we are in the single-payer movement, it looks like we're in what's called the 6th stage, and that's the stage before success. 7 is when you actually win, and 8 is defending that win and going on to the next cause or fight. We're seeing a momentum over the last year and a half that I haven't seen in all the years that I've been doing this. When the Republicans said that they were going to repeal the Affordable Care Act, and the Democrats said, we have to fix the Affordable Care Act, and we were telling people we need single payer, the grassroots came out and said, yeah, we need single payer. Nobody was like, we have to make the Affordable Care Act work. I think 8 years in, we kind of see that the Affordable Care Act is doing what it can do. It's not going to do anything more than that. And so people are really ready. We have a record number of co-sponsors for our legislation, HR 676, 123 co-sponsors. They created a Medicare for All caucus in the Congress now. 77 members of Congress have joined that caucus. I think that makes it one of the largest caucuses in Congress, so that they can communicate with each other and advocate for this. And just seeing last year during all the town halls that were going on around the country, in places that we didn't expect it, people were standing up and saying, no, we need a single-payer healthcare system. We want a Medicare for All system. And I think there was a Congressman Moran who was doing a series of town halls in Kansas, and everywhere he went in Kansas, people were saying, we want single-payer health care. So this is good to see. And also seeing more and more people using our language is a sign that we're starting to change the culture.
I would just add to that I was speaking with a New York Times reporter. I hope this article will be coming out in a couple of weeks. And what she was asking me about are, what does Medicare for All mean, and are some candidates kind of watering it down and getting behind some of these what we call faux plans? Medicare, you've maybe heard of Medicare X or Medicare Extra, or my favorite one is Medicare Advantage Premium Supplement for All. What? And oh yeah, and so I said to her, look, show me where the popular movement is for Medicare Advantage Premium Support for All, or any of these other plans. The American people are very clear about what they want. And if some of the candidates running are less clear, they'll get clear if they get elected when their constituents continue to confront them at town halls and bird dog them and write letters to the editor and call them out in public. They'll get real clear about their support for Medicare for All. That is our job, to make it impossible for our members of Congress not to do what we want them to do. And it's our job also as healthcare providers to have that policy understanding. I don't expect a legislator to understand health policy. That we can help them understand that. And your stories are always, always, always important. I'm going to be doing a workshop on lobbying at our annual meeting. And one of the things we say is don't hit your member of Congress with a ream of paper for them to read. Provide them with stories. That's what they remember.
Stories and bullet points. All right. Anybody else? There's a microphone down there. Do you want to just get up and, yeah.
Hi there. I'm actually a social worker, not a physician.
Oh, great.
But my question is, what role would Medicaid play, and then private insurance, in regard to like secondary insurances and things like that we're used to now? How would that?
If we get a national improved Medicare for
Yes.
all? So we wouldn't need a Medicaid anymore. We wouldn't need private insurance anymore either. What National Improved Medicare for All means is that we create a national health insurance that covers every single person living in the United States from the time they're born until they die. That it's one plan, we all pay into it through our taxes, and then it's there to use when people need it. And, if there might be a role for private insurance companies if they want to offer something that the system doesn't offer. But, like cosmetic plastic surgery or something like that. But the reality is that the more we have a need for any kind of a supplemental type of plan, the more expensive the system becomes because you have more administrative complexity to it. The simplicity of a single payer system is that, we could maybe have 5 or 10% of our healthcare dollars going to administration instead of a third of them. And that frees up a whole lot more money, hundreds of billions of dollars a year, for actual direct care. So it would actually be a benefit for everyone. And this is something that other countries understand. They've figured out, especially like if you look at Scandinavian countries or social democratic countries, that when you have a welfare system, a system for the poor, it becomes a poor system. But when everybody is in the same system, then there's an incentive by every person to make that the best system that it is. It creates this social solidarity. And so, how many of us are out there fighting with the people that are on Medicaid who are facing, cuts and work requirements and things like that? Because many of us, if we're not on Medicaid, we don't feel that, right? So maybe we're not sympathetic to that or out there with them. But if we have a system that we're all in and it gets attacked, and this is what you see in other countries, you hear from people about that,
Because it is a work. Okay. So you seldom hear, people who are opposed to single payer, they seldom come out and say that I don't think that people deserve equal health care. I think poor people don't deserve it, or whether that is how they feel or not. They seldom say that. They usually bring up logistics. The very trendy thing to say is that, in theory it works, but in application it doesn't. Say things about long waits and overcrowding in Canada and all this stuff. Could you tell us or point us in the direction of resources to where we can learn up on that, on the logistics and the incentive structures in place, and really the economics of single payer with case histories and stuff, so that we can more actively participate in that conversation and not just talk about the ethics?
Sure, and you're absolutely right. Sometimes people will say to me, I believe in universal health care, I'm just not sure single payer is the way to get there, right? And I often say, well, what is the way to get there then? So Physicians for National Health Program, pnhp.org, has a lot of resources, great resources. If you go to the resource page, it goes out by category. So if you go to the finances, it'll show you financial studies going back into the early 1990s at the federal and state level, showing how a single payer system works. But the easiest, answer to give to folks if you hear something like that is, well, every other wealthy nation in the world has some sort of a single payer system, and they're spending half as much money as we spend. They're covering everybody, and they have longer life expectancies and better health outcomes. So this is not an experiment. It actually works all around the world. And here in the United States, we have 2 single payer systems. We have the Veterans Administration and we have Medicare. And so we know while they're, again, the problem with those systems is they've been under attack. The VA is not being funded as well as it should be. Medicare has been under attack for a long time. But, when they weren't, when they were first started, and they still continue actually to work fairly well despite all of that. But there's a FAQ on pnhp.org, and what is it, like 24 pages long or something like that? You want to talk about?
We've just updated our website, and it now is, it's soon to come out, and it will be mobile friendly. So you can, on your smartphone, go to our frequently asked questions, get a short answer to your question, or you can drill down and we have a longer answer complete with references. Another thing on a moment-by-moment basis is Twitter. Follow us on Twitter. Follow Margaret and me on Twitter. I'm Carol Paris 7, and you're?
I think I'm Dr. M. Flowers, something like that. And I have, and I have 2, because I ran for public office. So my public office one was transformed into Dr. M. Flowers, I think, and then I'm M. Flowers 8 is the other one.
Okay. So I just tweeted a few minutes ago a picture of you and all that, so you can probably find that. But the reason I say that is that, I mean, I cover on Twitter things that are happening moment by moment in healthcare. So, and as do many other much bigger Twitter sites, but certainly PNHP would be a good one to follow. I don't know about Instagram.
I don't know. And then I also coordinate something called the Hope Campaign, Health Over Profit for Everyone, and so you can follow the Hope Campaign on Twitter as well. And does Kentuckians for Single Payer tweet, Kay? Not yet. Yeah, so Kentuckians for Single Payer is here. Dr. Garrett Adams with Kentucky PNHP is here. So you can look on Facebook.
And we also have a YouTube page for PNHP, and there are some really good talks there on a whole variety of topics. One of them that I love is Ed Weisbart talking about making the conservative case for single payer, because one of the things that we realize is that I don't want to pass this legislation with just Democrats only, especially not the way we passed the Affordable Care Act by reconciliation. That is not how I want to pass this. We have got to get bipartisan support, and it's not really that hard. There is a very good conservative fiscal responsibility case to be made for Medicare for all. So there's like I said, he does a great YouTube presentation on that, because it matters. If you're talking at Thanksgiving to your Republican mother-in-law, you're probably not going to get real far by saying healthcare is a human right. But you might say, you know, it might interest you to know that it's actually in my best interest. I'm taking care of myself in the best way I know how. Personal responsibility. If everybody in the country has health care, there's a public health reason for that, and then you can talk about social determinants of health, blah, 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 blah. But you've joined her in a value that resonates for her, personal responsibility. So Ed talks about that, and I just think it's a brilliant approach.
Well, actually, even libertarians have been convinced to support single payer. My partner, Kevin Zeese, ran for office in 2006 he was endorsed by, or nominated by the Green Party, the Libertarian, and the Populist Party. And the Libertarians, you know, the argument that he made, and you can make it very easily, is that it's the freest system. When we have a single-payer healthcare system, if somebody wants to move around to a different location, they're free to do that. If they want to change jobs, they're free to do that. They, choose where they want to go, what they want to get. So it's a liberating type of system. And
what do you think is the role of protest in this movement?
I think that we're definitely going to need to have a role for protests. So, with what happens through social movements is you start to create this tension, right? That it's a fight between the people who have the power and popular power to win. And part of that is they're going to get entrenched. They're going to try to block us. They're going to try to look like they're doing something when they're not doing something. And we have to exert some pressure on them, and protest is part of that.
My own Congressman Jim Cooper is one of the most recent co-sponsors, and he's a Blue Dog Democrat. I think he's probably from Tennessee. I think he's probably one of the most moderate Democrats, and he became a co-sponsor last year. And I like to think that not only is it because he truly is a health policy wonk himself, but he kept hesitating because of the financing issues. And every time I met with him, I said, Jim, you just have to understand, I'm organizing in your district, and I'm not going away. And I kept saying this over and over. And then when Donald Trump came to Nashville last March, last March, I went to the Trump rally and I snuck an improved Medicare for All sign in the sleeve of my winter coat. And I arranged, I knew I had to, I was talking to Margaret at the time and she said, "You don't have to do this, Carol." I said, "I know, but I just really think if I get a chance, I'm gonna do an action." Well, it turned out a resident at Vanderbilt who I had just met, shows up in line, and I said, "What are you doing here?" She said, "I don't really know. I had the day off and I wanted to see what this was about." I said, "I know why you're here. I need somebody to video my action." She said, "I can't get arrested." I said, "Just do it quietly, just on your phone. Just videotape me and then upload it to Margaret Flowers and she'll take it from there." And that's what we did. So when the president started talking about whatever repeal bill they were pitching then, I held up my sign and said, "Put your name on a plan that works, Medicare for all." And I just kept chanting that until the president actually had to stop talking. So I can honestly say that I have chanted down the President of the United States, and I've used him because he was not the target of the action. It was actually my congressman. I went to see my congressman 2 weeks later, and he was like, "What was up with that?" And I said, "I told you I'm organizing in your district, and I'm not even afraid to do something as outrageous as that." And 2 weeks later, Jim co-sponsored HR 676. So, yes, I think there is a place for bird dogging and protesting and being respectfully disrespectful.
I mean, it was during, one of the things that gives me hope, in 2009, 2010, when the health reform process was going on, and there were millions, tens of millions of dollars given to these progressive organizations to convince people that single payer was too much and that we should do a public option that would be a backdoor to single payer. It was all completely bogus, right? But they were paid a lot of money to convince people to believe that, and people did believe that, and that's how they got them to support the Affordable Care Act and not be active in single payer. Well, we were lobbying in Congress and trying to get them to consider single payer compared to what they were doing. And when it came to the first set of hearings, we looked at who was being asked to testify, and it was all industry people. Big pharma, big hospital associations, health insurance companies, business roundtable, and we said we want a national health finance expert to testify, and we had phone calls going in, emails. They said no. So that was when we went to the hearing, and we stood up and we said, "Why aren't we being allowed to testify? Why aren't you considering this?" And we were all arrested for doing that. And it was on C-SPAN, and we knew that this would get attention because we knew C-SPAN was going to be covering the hearing live, right? So the next set of hearings was in the Health, Education, Labor, and Pension Committee, and that was in May, and now this is in June. I'm at the beach with my family, and I get a call from Senator Kennedy's office. And they say, "Senator Kennedy wants you to testify before the HELP committee." And I said, "Oh, no. I know some real health experts. I'll put you in touch with them and they'll testify." And they said, "No, he wants you to testify before the HELP committee." So I was the first person to testify before that committee. And then when we got to the House and they started holding their hearings, the legislators said, "We don't want that to happen here." And they they invited people to testify. It was, again, this was all tokenism, right? I mean, they weren't going to really listen to what we were saying, but at least we got on the record, we got a chance to testify. During that summer, we put the call out, we brought in lots of medical students, nurses, physicians into DC to meet with the health staffers. We did rallies, we did protests. We almost got a single payer bill to the floor of the House. This was without a lot of resources. And then the House passed its version, and we got Senator Sanders to introduce a bill, an amendment in the Senate that would substitute the Senate health bill with a single payer bill. It was an 800-page amendment. It was like a full-out single payer system. And so the leadership in the Senate passed over that amendment. They were going by numbers. So we held another protest in the Senate building. We made these cutouts. They looked like cutouts of dead bodies. and put the number of people that die in each state because they don't have health insurance. We went to the Senate offices and we put them on the floor in the offices, and we were delivering statements and things like that. And we had media following us, and surprisingly, the senators got really upset by this. They didn't like that graphic image. And that was on a Thursday, and the next Monday we hear from Sanders that Harry Reid was going to allow that amendment to come to the floor of the Senate. So just with a little bit of protesting, we got things moving, and without a lot of resources. And it gives me, it makes me believe that with more resources and with more determination and with more knowledge about what, works and what doesn't work, that we can really be effective and we can win this.
And I also think that in 2009, we didn't have Twitter and maybe we had Facebook, but we didn't have a whole lot of social media. But now we can create our own media, even if the mainstream media is ignoring us. But another thing that gives me hope is that the mainstream media is actually beginning, occasionally, to cover this legitimately, much, much more than before.
Thank you guys for coming and talking with us, first off. Very interesting discussion so far. Some issues that have been very big nationally and specifically in Kentucky have been public education. Environmental issues have become increasingly more pressing, specifically in states like California that are really taking a lead. How do you see those other larger social issues that do significantly, they're entirely based on public interest in the public good. How do you see those meshing with the single healthcare system issue and moving forward in our country, especially with the anger and frustration that we've seen over the past couple of years, and specifically moving into the midterm election now?
That's a great question. I actually advocate on a much broader range of issues than just single-payer healthcare, and I believe it's really important. So some of the ingredients for winning social transformation is that you have to have a mass movement, and that means bringing together a lot of different parts of the population. And healthcare is something that, it's all related. The social determinants of health tell us that you have to have a good education, and you have to have a clean environment, clean water. The things that happen outside of our office doors really matter. And so showing up and supporting and being part of those movements gives you an opportunity to also talk about why we're fighting for single-payer healthcare and to build that solidarity so that we can work together for change. And so I also run an organization called Popular Resistance, and we run campaigns that unite lots of different groups to work together in a coalition for specific causes. So I think that's really important. And it's also really important, again, as medical professionals, we do have a role in these movements. People look to us and really appreciate it when we participate in these, and especially when you're willing to, to do whatever actions it is that they're doing and participate fully in those actions. They really appreciate that.
In the past 2 years, PNHP has worked with White Coats for Black Lives. We've participated in the Poor People's Campaign. We supported the actions last spring against all of the attempts to dismantle and repeal the Affordable Care Act. I was arrested in the Hart Senate lobby with a whole group of people from the ADAPT disabilities activists. And let me tell you, that is a powerful optic. Having doctors in white coats and disabled people in wheelchairs getting arrested, that's just not a good optic. They don't really like that. So we need more of it.
Just a kind of follow-up question. I know in some movements, especially like Showing Up for Racial Justice, that organization, they have identified like a tipping point number of people, white people, I believe specifically. They said that we need to change this, and it's not that many. I think it's like 3 million. white people's minds need to be changed to support racial justice policies, and then that will be enough to really tip things over as far as getting some real action. Do you have some identified, like if these med students are, can get 2 colleagues to kind of, get behind the effort, that would maybe get to a tipping point?
Yeah, that's, part of this research shows us that if you have national consensus on an issue, so majority of people that support that issue, and then you have 3.5% of the population is the number that they give, that's mobilized and active on that you can win. So that's important for people to understand that, because I used to think that, oh my God, we have to get everybody into the streets. But the reality is we don't have to get everybody. We just have to get about 3 to 5% of them out and active in the streets to get the change that we need. And that sounds like a much more doable number. So letting people know about that. And then, I come from Baltimore, where we have tremendous hyper-segregation, racial issues, disinvestment in black communities, and just outrageous, really, what's going on there. So I work a lot with supporting, people in our city. And when Freddie Gray was killed a couple of, this was 3 years ago, we immediately organized medical students and physicians to go out to the marches and rallies that were happening and wear our white coats and bring medic bags and, be participating in all of those, so that if the police were violent, which they were just literally pulling kids off of the street, because I also did jail support and I documented the injuries that people got while they were in jail. They were a little less likely to do that when there were, people in white coats out there in the crowd as well. So that was important. You've done a lot of work on police accountability in Nashville.
We've had 2 African American men shot in the back and killed in the last 2 years in Nashville, where I live. And we are currently have an amendment that is going to be voted on in November to have a citizen, a community oversight board to have a community oversight of our police department. The police officer who committed the last murder has actually been charged, which is at least a huge step, although he was booked in less than an hour. When I was wrongfully rearrested about a month and a half ago because I supposedly didn't show up for booking, when I had been told that our charges had been dropped and we didn't need to show up for booking, I was woken at 5 o'clock in the morning with 3 police officers and 2 patrol cars to arrest Grandma Carol. I really put up a big fight, let me tell you. I was frisked, handcuffed, and put in the back of a police wagon and taken to central booking. Took me 4 hours to get out of booking, although I do joke, not joke, it makes me just more aware of my white privilege, even in the process of being arrested, because I got out on my own recognizance because I'm white, I'm old, I'm female, and I'm privileged. If I had been a black person, I'm not so sure that would have been the experience I would have had. And it gave me a better understanding of why people run away from the police. Because you're not going to get a fair deal. You could end up not being able to make bail and then having your kids taken away from you while you languish in jail and lose your job. So, I don't know where I went with that, but at any rate, I just think it is all connected. So, yeah, my interest in the Community Oversight Board and my interest in having Nashville not give all our tax money away to big corporations has to do with healthcare. It's all related.
And sorry, we're a little over time, so I understand that people have to leave. But I was curious, in these students' immediate lives, so if we have Medicare for all, what does how does then the educational system change to meet that? Because I know when we've had discussions with, our office had discussions with students who we talk about, are you going to go into family practice, or, we talk to the dental students as well, about volunteering in certain areas, and some of the answers we get is like, we have an absurd amount of debt to pay back. We have to go for the highest paying thing to pay off all this debt. So I'm curious how, in New Zealand and your other experiences, how do these med students, dental students' experiences then change in those systems?
Right, so with the National Improved Medicare for All, we're, the bottom line then becomes health instead of profit, which is what our system is right now. And the backbone of a good healthcare system is a strong primary care. So there will be changes in reimbursement so that primary care doctors will be reimbursed better. But there's also some language in the legislation not fleshed out about medical education. I mean, we definitely need to move towards lowering the cost of medical education. When I went to medical school, it was $5,000 a year. I came out with some debt, but it was very manageable. And same with Carol. And those days are gone. And that dictates who's going to medical school, right? And then that dictates what kind of a doctor they are, how they practice. One thing that gave me really hope is that in 2010, the match in 2010, which was right at the same time that the Affordable Care Act was passing, and people had a lot of hopes about that the Affordable Care Act would change our system and solve the problem. We saw a higher number of people go into primary care in March of 2010, and I think it's like people, medical students, I've heard that the majority of medical students coming in are interested in primary care, but when the reality sinks in about the system, that shifts as the years go on. And in New Zealand, what?
In New Zealand, education is heavily subsidized, and the ratio of primary care to specialists is, at least 2 to 1, if not more.
All right, well, thank you so much. Check out PNHP, check out SNAP, and just find out for yourself how you're going to make a difference in the world. Every one of us can do it. There's nothing unique about us.
Thank you very much.
Oh, gotta turn off the... Okay, are you going to do that?